So now we're going to talk about treating delirium in the ICU. Due to recent updates and guidelines, we'll start to see a shift away from using first-generation antipsychotics such as haloperidol and a shift towards using second-generation antipsychotics such as quetiapine, olanzapine, risperidone, or ziprasidone. This change was due to a lack of evidence for haloperidol being effective in treating delirium in the ICU. Delirium is more likely to occur in the ICU for several reasons, the foremost being the fact that patients are critically ill. They spend a lot of time being sedated and treated with opioids, which can increase the risk of delirium. Many of them are treated with benzodiazepines, which is a medication that can cause development of delirium. And finally, a lot of these patients have higher prominence of risk factors such as hypertension, alcoholism, or previous history of dementia, as well as sepsis, which are all risk factors for delirium. Delirium can lead to long-term cognitive impairment as well as increased length of ICU stay, which is why it's such a huge concern, because this can lead to increased cost of health care. Prevention of delirium is usually focused on non-pharmacological measures. We like to cut down on the risk factors that can lead to delirium, so we're really focused on improving sleep quality, making sure these patients don't have interrupted sleep, that the lights are kept low when it is time to sleep, in addition to reducing the amount of noise that's going on in their room. It's also been found that early mobilization can prevent delirium, so they get those patients moving around as soon as possible. So there's not a ton of evidence out there to guide the use of second-generation antipsychotics in the treatment of delirium. They do come with their own set of side effects, so we do have to consider and rationalize our approach when treating delirium and think about those side effects as well as the safety profile of each individual medication. So let's start with risperidone. Risperidone is less likely to cause extrapyramidal symptoms like haloperidol will. Haloperidol is known to cause neuroleptic malignant syndrome, increase the QTc interval, which can lead to torsades, in addition to those extrapyramidal symptoms. So risperidone kind of moves us away from those risk factors. That is dose dependent. The higher doses, above 6 milligrams, you will see patients start to experience those neurologic side effects. So usually we would start off with 1 to 4 milligrams a day in 1 to 2 divided doses. It's also less likely to cause anticholinergic side effects in comparison to quetiapine and olanzapine, so we can take that into effect as well. It's less sedating than those medications. This may be a benefit in patients with hypoactive delirium, in which they are sedated and confused and lethargic. Risperidone isn't going to increase that sedation any further, which could be a benefit when treating delirium. Moving on to quetiapine. Quetiapine also has a low incidence of extrapyramidal symptoms compared to haloperidol, but it may cause orthostatic hypotension and sedation due to its action at other receptors. It does have a short life, so it's easy to titrate on a daily basis. However, it's only available as an oral tablet. Therefore, if the patient isn't able to take PO medications, we may be looking towards other options that have injectable forms. Doses usually start at about 50 milligrams twice a day and can be titrated by 50 milligram increments to a max of 400 milligrams per day. Olanzapine is also a safe alternative to haloperidol. However, it may cause sedation, which can be a problem in our patients that are experiencing decreased activity of delirium. It should be used with caution in patients with a history of diabetes due to its propensity for weight gain and sedation. And it's dosed at 5 milligrams daily for up to 5 days. Finally, ziprasidone. Ziprasidone is less likely to cause anticholinergic side effects, but out of the 4 atypical antipsychotics is the most likely to cause QTc prolongation. It must also be given with food, so again, like quetiapine, if these patients aren't able to take oral medications or not on a diet, then this is not a viable option. We would need to turn to an injectable form. Ziprasidone is the least likely to have to be a viable option in the ICU due to its effect on QTC prolongation. A lot of these patients are already prone to developing a prolonged QTC, whether it be the concomitant medications that they're on or previously existing arrhythmia. So we won't see ziprasidone used as often as we might see the others used. If you were to use it, the dose would be 10 milligrams every 2 hours, up to 40 milligrams per day. So we need to help providers determine which medication will work best for their patients based on patient-specific factors such as cardiovascular history, comorbidities, and risk for extrapyramidal symptoms or QTC prolongation. We want to suggest using an injectable formulation of risperidone or olanzapine if the patient is unable to swallow tablets. And again, we're avoiding ziprasidone in patients that have a propensity to develop prolonged QTC interval. Remind prescribers to utilize non-pharmacologic strategies such as early mobilization and improved sleep quality in order to prevent delirium and cut down on the incidence of delirium. Thank you.